Assalamu alaikum and good afternoon. I'll talk on a diagnostic dilemma of a young boy with acute chest pain in COVID era. My patient, 18 years young boy, presented with central chest pain. Initial ECG shows right bundle branch pattern with a steady change in anterior and lateral leads. Troponin I was raised 6-fold than normal. He had no history of diabetes, hypertension, smoking, or any other risk factors. Patient gave history of low-grade fever and upper respiratory symptoms 4 days back. Rapid antigen test and RT-PCR for COVID was negative. No family history of ischemic heart disease. He was admitted for observation in CCU and was diagnosed as a non-ST elevation MI and treated according to standard protocol. Serial ECG shows dynamic ECG change. Changes were worsening than the previous one. That's the starting ECG. There is a ST elevation in 1 ABL, and there is also ST elevation in V2, V3, V4, which is not a usual one. There is also ST depression in ABR and other leads also. And we do serial ECG. He has ongoing chest pain, central tightness, he was telling, and his BMI is 26, is 5 feet 10 high and 82 kg. So only that's a bit overweight. Otherwise, he has the history of junk food frequently, and no other risk factors. And we had the problem that ongoing chest pain, and there is serial ECG. There is ongoing changes. Initial changes was in the lateral leads. Later on, it's a steady change in the anterior chest leads, and his troponin was progressively rising. So we are looking for whether we are dealing with the acute coronary syndrome or something else. We try to exclude other thing also. We have done the echo. Echo shows completely normal, no residual all motion abnormality, normal LV, RV systolic function. And as you can see, that troponin, initial troponin was conventional one. It is 10-fold, almost 10-fold rise. And the later one, high sensitivity troponin, is 2,592. Next one is 16,702. So all this pattern is going on, and for evaluation, actually, both of his parents, they are doctor. So we had a pressure from them also was really going on there. So we had to go for the patient to the cath lab. And cath lab, as you can see, the right and left coronary is absolutely normal. There is no plaque, no nothing. So we are in a dilemma. So are we dealing as a SCS or what else? So diagnostic dilemma, whether it was a case of myopericarditis or Minoka, we plan to evaluate him further with cardiac MRI. Cardiac MRI showed no regional wall motion abnormality and no delayed gadolinium enhancement after contrast injection. So CMR actually focused to evaluate the possibility of myocarditis or Minoka, and they try to look for edema imaging, evidence for late gadolinium enhancement, SI ratio of myocardial over skeletal muscle, all this they try to look for. And actually, there is no late gadolinium enhancement, and there is nothing suggestive of myocarditis or not even the Minoka. So actually, cardiac MRI is also become non-diagnostic for this case. So normal LA, LV, and normal LV systolic function, and normal RARV and right ventricular function. Evidence shows normal cardiac anatomy with viable myocardium in all 3 coronary artery territories. So the problem is that if you can't label him, so then what treatment should he receive? So as the patient, as already mentioned, both the parents say, the doctor, there are many things that's coming out. Whether we are dealing myocarditis, should we give him some colchicine or something like anti-inflammatory drugs? So even we didn't prescribe, they started to take colchicine, and he received 2 weeks colchicine. And he also develops diarrhea following colchicine. And that's the last ECG that the patient have. Still, as you can see, there is T inversion and asymmetrical T inversion is persisting in the anterior chest leads. So actually, we, as we couldn't come in conclusion, our clinical context is could be myopericarditis, and we did not give him any drugs for a longer period. So managing chest pain in COVID era is challenging. Chest pain is multifactorial due to myocarditis, maybe pericarditis, type 2 MI, or pulmonary embolism. Timely arranging cardiac cath and intervention is difficult for fear of infection. So thank you very much for your kind attention.